Welcome everyone to the Disaster Response Collaborative March 4th session. This month we are meeting with our individual focus areas, and thank you to everyone. You've chosen pediatric surge capacity and capability. So welcome. We're really happy to have you with us. So before we get started, I'd like to read the acknowledgement. The Pediatric Pandemic Network is supported in part by the Health Resources and Services Administration of the U.S. Department of Health and Human Services. The content that is presented today is that of the authors and does not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the U.S. government. We will be offering continuing education for several of you today. So if you are interested in that, this tells you how. At the bottom, you'll see that you must attend the entire live session. You need to ensure to complete the session evaluation at the end of today's session and make sure that your name is on the session registration. So if you are under somebody else's name, rename yourself in your little picture, or you can add your name to the chat. And then at the main thing is to follow the instructions at the end of today's session. There will be a slide that will give you a code to put into the CE portal. So make sure you do that. Couple of announcements. We are very pleased again that you have joined us in the surge capacity focus area group. This session is being recorded, and the slides and the recording will be posted online later on. Please add your questions to the Q&A or the chat box, and we'll try to answer those throughout. We are offering, on top of the continuing education for individual sessions, physicians, we are also offering MOC Part 4 credit if you would like that. You cannot necessarily double dip, but we are offering MOC Part 4. You have heard us talk multiple times about the Pediatric Disaster Preparedness Self-Assessment for Children's Hospitals. We'll call this the PediPAC often, or the self-assessment. This is going to serve as the DRC's environmental scan. That is coming soon. We're getting closer. We're just waiting on a few minor tweaks. So be on the lookout for that in the next, hopefully, month. This is today's agenda. We're going to start with introductions of our speakers. We're going to talk about our surge collaborators and who has joined us. We're going to talk about key takeaways from the overview session back in December. We're going to talk about hospital patient flow, and then we're going to do our wonderful breakout session that we like to learn from each other and network with each other. We're going to review some resources, and then we'll go into next steps. Here are our objectives for today. I won't read these, but you can read through those. And then I will turn it over to Liz Foster for introductions.
Thank you, Julie. Welcome, everyone. My name is Liz Foster, and I will be one of the speakers today. I'm joined by Amina Hussein, Dr. Anna Lynn, Julie Shelton, and Carrie Wellnitz. And if you could for us, please add your name and institution in the chat so we know who is in the room with us today. Next slide. We just wanted to review a little bit so that we can get to know each other and know what institutions and where everyone's from who are joining this focus group area. As you can see, those states that are colored in green are the hospital institutions that are joining us today, and those that have the stripes in them represent multiple hospitals within those states. Next slide. Here is a list of all of those hospitals that are joining us in this focus area. I'm not going to read them all, but you can take a look to see just the vast amount of healthcare systems presented here today. Next slide. When we look at the types of institutions and the number of licensed pediatric beds, you can see that we really have a little bit of everything here today, but our two largest groups in the room today are those with between 0 and 49 licensed pediatric beds and 200 and 499. Next slide. When looking at the type of hospital, we have hospitals that are standalone children's hospitals, and we also have hospitals that are within healthcare systems. So you can see here that the majority are hospitals that are located within a healthcare system, but still a decent amount that represent standalone children hospital systems. Next slide. And we look at pediatric volume. Most of our collaborators here today have high pediatric volume, over 10,000 pediatric patients, so about 75%. We have the next highest category is low pediatric patients. So again, recognizing that our collaborators today make up a variety of pediatric capacity. Next slide. And who is in the room with us today? What types of participants do we have? We have about 30% that are doctors. We also have another 34% that are nurses. We have some EMTs, emergency managers, and then 20% make up our other category, which includes coordinators, emergency management personnel, administrators, pharmacists, and respiratory therapists. Next slide. And then I will go ahead and turn it over to Dr. Amina Hussein, who will talk to us about Surge.
Hello, everybody. Thank you for joining us. We're really excited to have you as part of our Surge work group. Next slide. Today, I wanted to go over just some of the, since we're all coming from different places, as you can see from Liz's description of our participants currently, we're all coming from different places, different hospitals, and with different preparedness levels. We want to start off by reviewing what we did in the overview, just to get everyone a little on the same plane. We talked about Surge and the different ways of looking at Surge. One of the main features of Surge is looking at it through the 4 S's. That's through system, stuff, space, and staff. When we talk about systems, it can be everything from our incident command systems to how to trigger activations, which we'll be talking about. The stuff is equipment, medications, and other materials, ancillary materials. The space can be at your location in your hospital or alternate care sites outside of your hospital. And staff encompasses quite a vast pool, but looking at everything from how to staff up, how to cross-train, how to do training, and also looking at our responders' wellness, so taking care of our staff. Next slide. When we look at the structures, one of the main structure features of a Surge is managing it through specifically an incident command system. And this is just a kind of a more general outline of an incident command system that you might look familiar to you if you use this at your hospital. We'll be talking about this as well at one of our group sessions, and just looking at the different ways and places that pediatric actually fits in. Some of those are highlighted and then again listed below in different areas where we have to have very specific pediatric focuses in those areas. And we'll discuss when we have that group session about how we need to integrate pediatric in those areas. Next slide. Activation is really important, and I'll tell you that it's way more complex than you think it would be for just telling everybody that you're starting a disaster protocol. You have to think about the different criteria that you need to make, who's making the decision, and how you're communicating this out. It might depend on different things, so it might be a little bit different based on the time of day, what type of hospital you're at, what type of surge is happening. If there's other disasters happening at the same time, like if this is happening during the middle of a pandemic and you have to evacuate your hospital. I'm sure some of you here are familiar with that as well. And then communication is such a huge piece of just the activation alone, but throughout the disaster. Think about everything about the platform you're using. It might not just be one. Always with every staff, stuff, space, and structure, you need to have redundancy. So thinking about the redundancy even within the communication, and then deactivation, specific to activation. We'll be going into a lot more detail about activation in April. So really looking forward to that group session. Next slide. We did some polls at our overview session in December, looking at what people's preparedness levels were. And that does not actually, that's not this pool of participants. It's the people who joined us in December, which encompass more than just the people who chose the Surge focus group. As you can see here, that people thought that they were actually pretty well prepared in space and systems. We'll bring up another slide later on that will show kind of some question marks there about that response, but that people felt that they had the least preparedness of their supplies. But we will definitely definitely give out resources and other things to help with all of these different S's. Next slide. And then the other question that we asked at that December overview session was what would you like to improve over the next few months? And system was by overwhelmingly the response. So, we'll go at this Surge focus group in terms of systems, but also discuss some of the other pieces that we thought people had focused on. Next slide. When we want to be a little bit more specific and understand this in a word cloud, understanding that this is more than just the people who chose the Surge work group. Reunification came up quite loud, but I think those people went on to the reunification Surge group. So we will not be touching on that as much here. We'll be talking a lot. You can see staffing is really big in training, drilling, communications. Again, staffing in very different ways is brought up again and again. So we'll be talking through all of those things when we talk about our structures. Next slide. And then just to end on one of the other things we discussed and we'll be discussing in detail today is the movement of patients. So as most of us know that a surge does not just happen in the emergency department. It actually takes an entire hospital to manage a surge. And if we look through how patients are arriving, whether by ambulance or on the back of a pickup truck or walking into the emergency department, hopefully through a single entry, then they could go anywhere from being discharged home straight from there or to a discharge lounge or transferred out, which is one of the hardest things to do, to the operating room, to the ICU, to a med-surg floor. But even within the hospital, you're seeing patient movement from the ICU to the ORs, back to the ORs, to the med-surg floor, or even from the ICU home. And again, from the med-surg floor, it's going all in all of the same directions. And so understanding that that takes more than just the emergency department, it takes the entire hospital to manage a surge. Next slide. We're really excited to have Dr. Anna Lynn and Dr. Kari Weltnitz present on this and give us a lot more detail and insight into how we can do this well. Over to you, Anna.
So this is our first poll, and just kind of getting an understanding of which areas beyond the emergency department have participated in your MCI exercises. So you can see the different choices there. We're including some of our ancillary services like diagnostic imaging, lab services, and transfusion services, but also kind of going beyond the emergency department into the inpatient realm of perioperative services, acute care, intensive care. If your facility actually also cares for pregnant women, obstetrics, and then your ambulatory service areas. And I think we're starting to slow down in responses. We'll give maybe another 30 seconds. Ooh, lots of responses now. Can we move to the response page? Ooh. Can you hit the see more maybe and see what
I
happens?
apologize. All the testing done is not, doesn't seem to be working.
Visual settings. Um,
I think we need to go back. Apologize, everyone.
It looks like you have an instruction slide inserted into the PowerPoint. If you go to view and then, to the big view,
The big view of,
the slide.
oh,
Yeah. And then if you hover at the bottom, there may be a response instead of instruction slide. That,
no,
no?
there's not.
We can just move on.
Yeah,
We can share the
do this.
results with you afterwards, and then in a supplemental email. Okay, next slide, please. So when you're thinking about patient movement beyond the emergency department, I usually think about this in terms of waves, right? So the initial wave that comes to the inpatient unit is as you're trying to empty out the emergency department to make room for patients who are incoming from a mass casualty. So what does this mean? It means that you have to initiate a rapid disposition, and some of these patients will be rapidly discharged home from the emergency department, and a small amount of patients who may have incomplete diagnostic workups and maybe incomplete intervention measures may need to be admitted quickly to the hospital. And they can be admitted into different areas of the hospital, the treatment center, or your ORs, the intensive care unit, or medical surgical units by direct admission. And then subsequent waves are really going to be based on the MCI event. And so the impacts like the surge impacts are actually going to affect the hospitals at very different times. So we'll have this initial influx before even the first MCI patient arrives, but then we'll have subsequent influxes that happen after triage and stabilization within the emergency department. And again, they can go to all three areas of the hospital, and these may be impacted again at different times, where we will see the first influx of patients generally epidemiologically will be the walking wounded who self-present from an MCI if it's not a closed scene, followed by more moderate and severe cases. Next slide, please. So just for this initial wave, thinking through who actually needs to be notified of an event, an MCI beyond the emergency department, because there are really implications to help you decant that emergency department. So who do you call to rapidly admit patients from the emergency department? And before you get to that, you might want to think about who do you actually call on a day-to-day operational basis. Who needs a patient handoff? Is it just the physicians and nurses, which is for us, it's physicians and nurses and whoever else needs to be involved? And then what changes need to be made to actually cut that admissions process very quickly? And so a lot of times people may approach this differently. We at our institution approach it into a single person that gets called. And who triages the cases to other service lines and other pediatric clinicians. And the handoff all happens at the same time. And so like we're trying to streamline that admissions process so that we can empty out the ED as quickly as possible before the first patient from the MCI arrives. The second thing is really how are you going to move those patients and how are you going to move them very quickly? So who will transport the patient? Will it be the transporters? If it's somebody who's critically ill, you may need some not just a transporter, but a nurse or somebody who's able to do that, or a respiratory therapist. What kind of equipment is needed for safe transport to get from the ED to the location that the patient is admitted to? And how can you rapidly get those resources to move patients? And so thinking through that process, because you don't want to empty your ER, your transporters may need to be available to actually bring in patients from a triage area. So you might not want to utilize the transport. Are there less impacted areas that can move patients safely from the emergency department into the hospital? Next slide, please. So when you're planning, some of the assumptions that I make is that you follow the normal daily processes as you can, until you can't, right? But I think just by the nature of children's hospitals being at capacity all the time, we actually do a lot of the triage in our heads, like on a daily basis. For example, our ICU doctors, like Dr. Wellnitz, probably identify 2 or 3 movers, right? Patients who can be safely transferred from the intensive care unit to the acute care unit at any given time. And then similarly on the acute care side or the med surg units, all of us who are in hospital medicine are constantly thinking of what does this patient need to get discharged home? So these thought processes are actually critical and maybe extremely useful when you're thinking about patient movement through the hospital. The second planning assumption is that bringing in additional staff may not be possible or timely. If you look at the epidemiology of mass casualty, it's hours. And quite honestly, it will take 3 to 4 hours for us to discharge some of our patients from the floor, even if they are identified as an early or a rapid discharge. The third assumption that needs to be made is that your interfacility transfer process, which Dr. Hussein had alluded to, may be compromised or not even possible. If it's a large enough event, all of your EMS resources may be tied up in that event and transporting patients to multiple hospitals within the region. And then the last planning assumption is that there's certain areas that exist within the hospital that may be reprioritized for inpatient care. Next slide. So just kind of thinking through this, the patients are going to move from different areas at different times. So based on what the nature of the mass casualty is, the type of patients and the acuity of patients is going to determine where you need to decant, right? So if you have a lot of patients who, for example, have penetrating traumas and who need like hemorrhagic stabilization and control, then you can imagine that the treatment center or your operating rooms need to be decanted, which also includes their PACU. The PACU will, constantly assesses for readiness to transfer, but some of your patients may need to go to the intensive care unit. Some of your patients may need to go directly into the acute care units, and they may not be fully recovered. Similarly, after that first wave of patients, and even the second or third wave of patients, there's bidirectional movement between the treatment center or operating rooms, intensive care, medical surgical units. And there's one line that I forgot here, which is between the operating rooms and the medical surgical units, as well as discharge from hospital. But understanding that discharge from hospital may be slower than the initial onslaught of patients. It helps to actually identify and plan if you understand where your natural bottlenecks in patient flow are on a day-to-day basis. So that will bring us to our next poll, and I don't know if this will work, but we'll ask it anyway. And if we can't show the results, we will bring the results to you guys later. But in your facility's daily operations, not in an MCI, where is the bottleneck? Oh, this one works. Bottleneck to patient flow. And Julie, I'll look to you to let us know when there's the majority of people have been able to answer.
I still see a lot of movement.
Okay, it looks like the ICUs are a heavy contender here, and maybe Kari will be, or Dr. Wellness will be able to speak to that. I find it really interesting. Our institution, it's the medical surgical units that is the bottleneck, not our intensive care units. But again, like as you think about, well, that may be a natural bottleneck, but then is there a way to actually make the bottleneck a little bit larger in certain circumstances? And so that's something to think through as you're planning for an MCI beyond the emergency department. Next slide, please. So breaking this down, because we love our 4 S's in emergency management and disaster preparedness, really looking at space, right? If you're already operating at capacity, what are some alternative care areas that can be activated for a sudden surge of patients? This may be critically ill patients, it may be non-critically ill patients, but what are some alternative areas and what space requirements are actually needed? So you wouldn't necessarily want to place a bunch of patients who need respiratory support in an area that does not have access to oxygen. And that access to oxygen may not necessarily be a head wall. It may be large tanks that you're wheeling in. But again, like you need to have access to certain types of supplies, which we talk about a little bit later, but definitely think about what considerations you need and what types of patients can go there, especially patients who may need cardiorespiratory monitoring. Not all sites are created equal, and so thinking through those ahead of time are important. Staffing is always a huge issue, and in an MCI that is large enough, you're not going to be able to keep your standard nursing ratios, and you will be operating in crisis standards of care. There's a really great resource put out by the Society of Critical Care Medicine on team-based staffing models of care. But other things to consider is task shifting. So you may actually ask caregivers who are at the bedside to do personal hygiene issues or enteral feeds so that you can actually offload those tasks from the healthcare worker who could actually be utilized in more medically based interventions. We talked a little bit about supplies. If you're planning on moving into a space that doesn't normally take care of pediatric patients, for example, our institution, we have an obstetric unit. We did overflow patients into our obstetric area, into the maternity wards there. And one of the things that we found was that our nurses were running ragged because they could not actually focus on patient care because they were more focused on acquisition of supplies to care for those patients. And so this resulted us in developing pediatric carts that could be wheeled into any locations to accommodate pediatric patients. And then the last thing to think about, structure and systems. What waivers will you need to talk with public health about to accommodate a patient surge? If you're in an area that has labor unions, what discussions need to be had with those unions to actually plan ahead of time, because the time to have these discussions is actually not during an MCI. And so making sure that the institution has those structures and systems in place to support patients during this type of an event. With this slide, I think I'm going to turn it over to Dr. Wellnitz.
And so oftentimes when you're starting to consider surge outside of the emergency room, one of the issues that can arise is engaging the rest of the hospital. Because a lot of times, especially with the current flu situation and the triple demic a couple years ago, people are like, well, surge has been our bread and butter. Why do we need to think about that right now? And so one technique that can be helpful is considering having your inpatient units and your ORs plus PACUs participate in a reverse triage tabletop drill using real-time census and patients. And so the way it was done in our hospital was there was a designated time where the nurse managers knew we were going to come and sit down and discuss, okay, if we're injecting a bolus of 5 to 10 patients or whatever would stress the system into your unit, which patients do you feel like are the most stable to move out? And then what would we need to do to get that to happen? And so that was really helpful because it pointed out some barriers that may need to be addressed, such as, okay, if people are just waiting on discharge because they need to pick up their meds from the pharmacy, can someone be a runner to the pharmacy? Can we send them to the adult discharge lounge with their parents to wait for the medications? In my children's hospital, we have one floor that does respiratory patients, and the other 2 floors do not. And is there a way to sort of expand what the traditional non-respiratory floors would take along the lines of simple nasal cannula and maybe not high flow? And so doing these types of drills, even as like small thought exercises, can be helpful to identify some of the barriers that may come up. I've been looking in the chat and I've seen that one of the things that has come up is how do you handle the behavioral health patients that are boarding in the ED to try to try to create room. And I think this is an absolute great way or entry discussion point to start talking to your behavioral health teams about how would that happen? Is there a place on your campus that isn't necessarily a traditional medical unit, but could be appropriate for certain behavioral health patients to be kept while awaiting bed placement, whether it's with your institution or a different one. And so because every place is different, sometimes really breaking it down and having people do this can be useful. And I like the suggestions of gaming theory that I'm seeing in the chat.
So this is a follow-up poll. So the first poll is what areas have you included in the past? This is what you will be including in your next MCI exercise. Are we getting close, Julie?
I think so. It started to slow down.
Okay. Really interesting. I like that we're doing acute care since that's like near and dear to my heart, and including ICUs. I think those are wonderful places to start. I'm really interested in that transfusion services wasn't going to be involved. I don't know, maybe it's because they're already involved. But we actually found a lot of lessons learned by involving our transfusion services in terms of the mass transfusion protocols if needed. And, we ended up deciding as an after action report to increase the PAR if we are notified of an MCI exercise of blood products in the ER. oh, you can only pick one. Oh, shoot. Okay, next time we'll do a select all, but thank you. Next slide, please.
All right, so the next thing that we're going to do is break into breakout groups. And I'm thinking, Julie, that 4 should be enough since we wanted to keep the groups a little bit larger this time. And we'll probably spend, what do you think, Anna, like 10 to 15 minutes in the breakout? I'm trying to look at the time and assess what we still have time for. 15 minutes?
Yeah, I think we could do 15 because we'll have to come back and have follow-ups.
Debrief, yep.
Yeah.
So we'll do about 15 minutes in a breakout, and really we wanted to discuss what's currently in your surge plans. So we have some prompting questions and just looking to have a broader conversation about the surge plans that you currently have, and what works and what doesn't work. And then we'll come back and debrief, do some discussion on resources, and then wrap up with some next steps. So I'll turn it to Julie, who I think is going to kind of get us assigned, and you should have a facilitator. We have about 8 people identified as facilitators, so there should be more than one in each of the rooms to help lead you through that conversation. So just hang tight with us and we will see you back here in about 15. We can just maybe do a quick little debrief from each of the groups. So does somebody from group 1 want to share what you discussed in your breakout?
I can do it. I think we had a really nice discussion about, as always, everyone has similar problems. As far as, I think one of the major barriers is everyone wants to have multiple groups included, but everybody's busy. Everybody's running on different schedules. It's always hard to get everyone in the same room at the same time. Some places obviously are more successful if they have people who are super motivated within those other divisions or other departments. But I think there is some overlap in that a lot of people have at least some basic surge plans, particularly within kind of with the initial event and with the ED. But that, as I said, kind of the struggle of trying to get everybody, really all of the different divisions and departments in the same room to really kind of hash things out, make sure that everyone is contributing and everyone has a voice, and then just trying to find those times of trying to get everybody's feedback and get everybody's kind of thoughts so that things run smoothly. And then the last part being that, well, there's a lot of other stuff, but to briefly summarize, also just this idea of you get a search plan and there are certain areas that are kind of just vaguely put, and that those efforts to try to get specificity, which may say something like, this is how we're going, surgery will do this part, but it literally doesn't specify anything. Trying to get that specificity from divisions and other departments can sometimes be difficult as well. Hopefully, if anyone from group 1 feels like I missed something, please let me know.
Thanks, Joyce. Appreciate it. Group 2?
Okay, I can call out. I can give anybody a chance that wanted to, and please chime in, please, if I've missed something. So there's a lot of discussion that was, I think, a little bit broad, and that was great. One of the ideas was that, people have a lot of plans that are more general, like it has been stated already, but doesn't include pediatrics, and need to actually incorporate pediatrics into their plans that in a way that is going to be useful and practical. And so looking for more ways for having pediatrics specifically into the general plans. Another center is more rural and doesn't actually have the space or capability to expand out and can't divert. So they need to take everybody. And how do they accommodate a surge when they don't really have the resources outside of that to go anywhere? So that was a really good point. Also making actionable, making very specific and actionable items that people are willing to move forward on. I think people get stuck and say, okay, so when do we call it a disaster? When is it a surge? When is it activated? Is there a contingency that we can do before actually having the surge? What is that contingency? Is people willing to do that contingency? And then let's see, we had great discussions about supply chain and, you know, having carts. Is that the best option? Is there other options to having carts? Who's managing the carts? Who is making sure that the materials don't expire and continue to maintain it? And is it all the right supplies that we have that we need? And do we have them all in the right areas? And then how do you replenish the carts as you're going through the disaster? So I think I hit on most of anything else that I missed. Group 2. Somebody had mentioned a playbook that they have the disaster surge plan, and then they have a playbook that is actually the action items, like a checklist of items that we have task sheets. So it's very similar to that, and I really love that idea because the plans in general can be really onerous and sometimes hard to understand if they're written in the more vague JCO management. Oh, thanks, Stu.
Awesome. And then we have time for about one more quick update if group 3 or 4 want to provide anything that maybe wasn't discussed yet.
I'm group 4, and I just want to congratulate one of our teammates on group 4. Discussed a very robust way to include children in the drills that was non-traumatizing to the children, but included using staff children who'd been very well prepared and had child life facilitators and their parents with them. But it made for great drilling. We really focused on gaps and strengths and tried to swap back and forth who had gaps, what were their gaps, and what were people proud of. One of our group, Lisa, shared that she's at Cooper and they've really started to focus on incorporating children into the plans since joining the DRC's collaborative. So that's a children's care within a larger system. But the children's centers have different issues. You know, we had our DC Children's Friends here who are in a very vulnerable area of the country in DC and feel that responsibility and create surge, think about their gaps and think about their risks really strongly. And it is really hard to get people outside the emergency department to want to drill. Everybody in the emergency department is pretty into this, but anybody outside the emergency department is so focused on everyday work that to incent them to actually practice is truly an art of trying to do it, get them to engage in practicing. So one thing we do in my shop is the mini drill. We try to take small bites, try to eat the elephant one spoonful at a time by having units do mini drills. And yes, is it perfect? But it gets people used to drilling in a digestible way. But doing a strength and a gap analysis is probably really valuable to see what you got to how to prioritize working on this. And so did I miss anything, group 4? Any other concepts? Thank you.
Thank you, Marie. We'll go to the next slide. And I think we have one more poll. So if you would please populate this, we're not going to stay too long on this slide, but I think this will really help us develop future sessions. So what areas of your surge plan would you like to focus your attention on for the DRC? And if you could just please contribute to that, that'll be super helpful. Next slide.
We'll pause for just a second so they have,
Okay.
because when I switch slides, I think it cuts off.
Oh, okay. Sorry about that.
We'll give them just a second.
Okay. What's a word cloud?
There we go. The focus area sessions, so everybody knows, are only an hour and 15 minutes. as opposed to our larger collaborative sessions that have been an hour and a half. And so we're losing 15 minutes, and we want to make sure that we get your feedback and, you know, have those robust conversations from the breakout sessions at the same time. So we'll get through the end of the slides, though. This is beautiful.
And then Amina, do you want to run through a couple of our resources?
Yeah, I just wanted to let you know some of the resources that are gonna that are made available to you. This is a pediatric surge playbook that's out of RAPM from the the RAPM Disaster Center of Excellence. This is a great resource on kind of longer term surge and expansion of resources from kind of your basic and all the way through. There is also some additional focuses on respiratory stuff that's really helpful, but definitely worth looking through this surge playbook. Next slide. This is one of the just a really good, really quick 2-page sheet on some winter viral surge themes that you might see coming and causing surge problems. Examples here that I want to just put both pages on there so you can kind of see what's there, but staffing strategies, you know, communication and coordination, supply chain readiness, so things to think about. And I know that we are in March, but it's never too early to start planning for next winter, and we still haven't seen enough flu B yet, so I'm still waiting for that to pop its ugly head. So still useful items that will come in way. Next slide. This is another great resource that is made from the PPN that includes multiple links and resources that you can link out to for more information on various respiratory issues and other kind of viral surge items that you might find helpful. Also goes into ways to maximize your space and supplies. Staffs are going through the kind of 4 S's, but a great resource again to look through more of just that management and capacity building. The one thing that I like about this is the management pieces. So it gives you really nice templated things on, you know, if your center is surging and there are maybe other centers around that want to transfer a patient and they just need to hold on to it a little bit longer. Some of these items can be helpful for them that you can kind of forward on to them to hold on to those patients a little bit longer because you don't have the space right now to take them. Okay, next slide. And this one should be coming out very shortly. This is a great resource for all hospitals, so not just pediatric centers, but all centers that ever see kids, even rarely, and how to incorporate pediatrics into their regular disaster plans. So it takes kind of a lot of core areas and just walks through a patient's experience through an MCI surge and where pediatrics needs to be thought of within each of those pieces of the disaster plan, the surge plan. Next slide. And I think this is just to highlight that that within the EMSC also there is the pediatric surge capacity portion of the checklist that you'll find very helpful to just kind of going through and making sure that you've hit kind of all the pieces. If you want to focus on a specific area, you can also just pull out those from the checklist to use.
And I will say that the EIIC, this disaster checklist, is a lot of DRC is based on this checklist. So if you have not looked this over, especially with surge capacity, or if if your hospital has chosen a second area of focus, to make sure to review those thoroughly. I think this is where I take over. Thank you, Amna. So expectations, we just wanted to remind you of some of the expectations for participating in the DRC. Many of you have formed a team, participating in sessions. You're going to have an environmental scan, which is called your PDPAC. It'll be coming soon. I mentioned that earlier. You're going to be conducting exercises and drills. And so hopefully you have your first tabletop exercise planned, either through our PPN virtual tabletop exercises or on your own if your hospital is doing it on your own. If you have any questions about that, please feel free to email dncppn@austin.utexas.edu. It's in the slides, and I'll also put that in the chat. But if you have any questions about the exercises, let me know. We're going to ask you to start reporting out best practices and lessons learned, especially as you start doing your tabletop exercises. We want to hear from you. We want to hear what you learned, aha moments, what didn't go so well, what we could do better, because we definitely want to share with each other and work together on how to make this the best response plans as possible. And part of that is, how do we make a good tabletop exercise? There are several resources for you. Again, I won't go into too much detail because they're all written on here and they're on our website. So if you have any questions about that, feel free. I will point out this intervention bundle guide and process measures. We are about to launch a website specific web page for surge capacity. So be looking for that. And we will also let you know when that is up and running. So here's your remainder of your timeline for DRC. You've got a focus area session today and then April. And then in May, we'll come back and meet with everybody, all the hospitals in DRC with a full collaborative session. And then that cadence will continue for the rest of the remainder of the DRC. If you have chosen a virtual tabletop exercise with the PPN drills and exercise team, you should have chosen one of the surge capacity dates. If you have not, feel free to email me and let me know. We can get you signed up for that. That's just a little information on the tabletop exercise. We presented that last month, so won't go over that too much. Our next session is going to be April 1st, same time, same place. When you registered for today, it will give you the same link or the same link. The same link that you used today will get you into the May session. May 6th, full collaborative session, that registration will be out by the end of this week. There's a new episode of the podcast, so make sure you go to the PPN website and look for that. This one is from a hospital, I believe in California, about a bus accident. So always great if you haven't listened to those. Okay, here's what everybody's been waiting for. Our CE. Okay, so there's the session evaluation. On the screen, you have your VAKVEC code to put into the portal to obtain your continuing education. Once you've completed your poll, feel free to close out of here. If you are, I launched evacuation. So on that third question, instead of based on this session, my knowledge about need for planning for evacuation, it's your need for planning for surge capacity on this one. I will switch those polls and make sure that I have the right data for the right session. And you will get credit if you are in the surge capacity and are completing this evaluation poll. I will make sure that the powers that be know that you're in this session for those continuing education units.
I'm sorry, what were we supposed to text again? VAK what?
Oh, I'm sorry. I'll go back. So this
Thank
is
you.
for, yeah, absolutely. The session slides and the recording will be posted on the website within the next 10 days. So all of these will be up there as well.